Thank you for tuning in to the Louisiana HIMSS Podcast, where we have engaging conversations with Louisiana healthcare leaders. This podcast is a production of the Louisiana chapter of HIMSS, the Healthcare Information Management Systems Society. Please welcome our host, President of Louisiana HIMSS, Sidney Bennett.
Welcome to the Louisiana HIMSS Podcast. I'm your host, Sidney Bennett, President of the Louisiana HIMSS Board. We'd like to thank, first of all, our annual sponsor, ASCOM. If anyone would like more information on ASCOM, you can reach out to Sean Fisher at sean.fisher@ascom.com. He also serves with me on the Louisiana HIMSS Board. Today on the podcast, we are going to be diving into the world of all things healthcare IT policy, including One Big Beautiful Bill, of course, but also patient identification matching and other policies. So joining us today is Tom Leary. Welcome, Tom.
Hello. Thanks for having me here today.
Absolutely. Tom, you are the Senior Vice President and Head of Government Relations at National HIMSS. And you've been with HIMSS for over 2 decades, I think, right?
Yeah, celebrating my 22nd year next Monday, as a matter of fact.
Well, that's incredible. You must really like it there.
I do. Yeah, it's never a dull moment, and never the same topic, facing you. And it's as the topic has grown both nationally and globally, it's been a nice challenge that I'd love to talk to you about today.
Awesome. So you lead HIMSS's digital health policy development. Tell us a little bit more about your role at HIMSS.
So with the government relations team and the informatics team are both part of what we call the mega team. We're responsible for developing policy that is reflective of both the concerns of our membership, but also more importantly, focusing on the vision and mission of the organization. So, as we've gone from being strictly a U.S.-based, U.S.-focused government relations team, for example, to more of a global endeavor, we've realized that the policies that are needed are very much borderless. So whether it's cybersecurity or information sharing or patient safety, all of those issues are very much on the front of mind of policymakers on every continent. And as HIMSS has expanded to be a global organization, we've had to make sure that our policy principles and our guidance and recommendations to governments are consistent with what's happening globally. So that's one part from a policy perspective. And the other piece with the informatics team is that we develop a lot of content for the membership, particularly the members that are that are part of nursing community, physician community, long-term care. Making sure that we're creating content that's both educational, but also listening to their needs and their observations so that can help influence the policy part of the team. It's wonderful. I get to work with 19 people who are incredibly passionate about their component, but more importantly, they're part of a matrixed approach, so working on behalf of the membership and on behalf of the vision and mission of the organization.
Thank you. So how much of your role is focused on domestic health IT policy versus global policies?
It's right now it's probably about a 50-50 split. As you can imagine here in the U.S., I'm sure we'll get into it. There's quite a bit of activity going on between legislative change and regulatory change, and quite frankly, just executive order and initiative announcements from the Trump administration. So it's not even regulatory change yet, but so there's those components that have really over the last 7 or 8 months have gotten very busy, and at the same time, work that HIMSS is doing, that we're doing with the European Union, with the WHO in Europe, we've had to pay very close attention to both the 26 countries that are part of the European Union, and then more importantly, the expansion of the 53 countries in the European region of WHO, which stretches into some parts of Eurasia that I didn't know that some of these countries existed when we first started interacting with WHO Europe. But and then of course Asia Pacific and LATAM or LATAC, the Latin America or Latin America and Caribbean, they're very much interested in a lot of the same issues. So all of that equates to about 50% domestic, and then the other 50% shared between Europe, Asia Pacific, and then LATAC regions.
That's got to be super cumbersome to try to keep all of that straight, all the different regulations and laws and all of that of every country that you're working with.
We can't say that we keep up with it 100%. So we have a philosophy of deputizing individuals from the region. So whether it's something new that's happening in Louisiana or something new that's happening in in the Caribbean, with our friends of the NHIT Collaborative, we try to leverage the knowledge of both our staff and the membership to help to get the HIMSS mission, stay focused on that, but really get our position or our recommendations into government, and then at the same time hearing from those individuals, hey, you ought to worry about the California new legislation on this, or Arkansas, or quite frankly, Romania, or any of the other countries that we try to interact with.
So you spoke about this a little bit, but just curious, you've been at HIMSS over 2 decades. What do you love most about working for HIMSS?
Quite frankly, people say the people, but I think it's the impact that HIMSS has on people. So today, just for example, I had a doctor's appointment, and the one patient was just standing talking to both the staff and the rest of us in it's a small waiting room. So he said that he had a new Medicare card because there was fraud. Well, I was able to say, hey, that's part of that is a result of some new CMS policies, and they've really tracked down some of the fraud that's happening, particularly on some wound care issues for people who aren't actually have wounds, and so and being able to then parlay that into a conversation not only with the staff at the doctor's office, but being able to educate the patients or people from the neighborhood who are about the impact of AI on healthcare, and what does it mean for if they have my information, and how do I make sure that it gets to the hospital? And so I think that's the number one thing that I love about this job, is being able to see what all of our members do, and the policies that we're trying to steer, see them in action and impacting people in their everyday lives.
Awesome. Well, thank you for all that you're doing to help impact things. How would you say, 2 decades is a long time. I'm sure healthcare IT policy is involved a lot over your tenure there at HIMSS. How would you say, the organization's approach to healthcare IT policies really evolved over that time period?
At the beginning, we had to explain to people who we were, why digital healthcare was important, and how we could be helpful in teaching them how to get from paper to paperless. Now, HIMSS is a recognized name across the globe. In fact, you hear about in India, we had one member who said that there was a CP HIMSS review book that they had gotten one copy of it at the university he went to in India, and they took turns using it and passing the CP HIMSS test. And now half of them are in India, half of them are in different parts of the world, but they all know HIMSS, and they're all very passionate about maintaining not only their certification but helping the organization and the overall membership expand. So I think that's a really a key issue of seeing how we are a global brand, we are a global presence, not just from a policy perspective, but really the educating the current and next generations of health policy leaders on the importance of leveraging digital healthcare to maybe not save money, but I like to say that it's not just about saving money or being more efficient. It's really about finding ways to improve on the care outcomes for patients and providers and caregivers. All the three legs of the important that important healthcare stool, if you will.
Absolutely, agreed. So I've heard you speak a bunch of times at conferences, podcasts, whatever. You have, I think, an incredible ability to remain politically neutral when speaking about healthcare policy, and I'm sure that's got to be extremely difficult. So a lot of these healthcare policies that we're talking about are very polarized. There's a lot of widespread opinions out there. So, one, first of all, how are you able to remain so neutral? And two, how do you go about trying to influence healthcare policies without bringing your own personal opinions into it?
Sure. I appreciate that question. It's probably the most thoughtful question I've received in quite some time, at least all year. So congratulations on the most important question.
Thank you so much.
It's really good. But when it comes right down to it, it's we have part of the preamble of the HIMSS Public Policy Principles talks about working to leverage digital healthcare in countries, regardless of what their political landscape is. And some would argue that there's been a lot of change here in the U.S. in the last say decade, but our issue has remained nonpartisan or bipartisan, really nonpartisan, because it's about helping people achieve better outcomes. So if it's the patient who deserves to have the information in the right place at the right time so that the right provider can make the right decisions with them, then it makes it really simple to focus on the nonpartisan or non-political approaches that can be made to achieving both policy development and then, quite frankly, the outcomes that we're hoping for. The other part of it is just that we have an opportunity when you're not caught up in either the left or the right or the whatever. If you're focusing on the solutions, you can have better dialogue because the person who may not agree with you on other issues can agree with you on, let's have a dialogue around, let's get to the best solution. And I think that's the beauty of HIMSS, and it's the beauty of health IT and digital healthcare in general, is that we're trying to achieve the HIMSS vision of better health for every human everywhere, to realize the full health potential of every human everywhere. So being able to focus on that's how you're able to keep the partisanship out of it. Quite frankly, though, it's when you're in a conversation with maybe in a speech with a crowd, just making sure that if you talk about a certain component that might seem more left-leaning or Democratic-leaning, making sure that you talk about the other side or the other sides, so that everybody understands that we're trying to get to the end point that's better outcomes, better healthcare, more efficient healthcare.
So how do you go about pushing policy that is going to get bipartisan support from all the sides?
It's there again. It's a great question. What we focus on is those outcomes, and if you look at maternal health, for example, they're struggling to get a Republican in the House of Representatives right now to be upfront, now that Congressman Michael Burgess from Texas, OBGYN, is retired. There's the issue of maternal mortality that both sides agree on. So focusing on what's bad, what needs to be fixed, and really talking to not just at the heartstrings of the individual, but what's the financial implication? What is the inefficiencies that you're trying to tackle? Picking on cybersecurity, for example, nobody wants to see Medicare or a health insurance company lose data, lose upwards of millions and billions of dollars, and just you think of the Change Healthcare, the cyber attack. It not only did it cause a disruption in the financial aspects of and my brother's a dentist, and he's part of the clinic that that was out hundreds of thousands of dollars over the course of the weeks that the system was locked. So that has the financial implications, but you don't want to see neither party wants to see healthcare shut down. So we talk about the cyber aspects, and we talk about what are the steps that can be taken to achieve more protected healthcare data, at the individual level, at the community level, and what can we do to work together. So it's understanding the interests, perhaps, of each party or each I'll just say each party, and trying to bring that into the discussion, not making it so complex that you're doing mental gymnastics, or in order you're twisting yourself in a ball trying to make sure that this person or this side's point is brought in, but finding the foundational interests of both parties, as in the U.S. or multiple parties, in Europe or other regions, and coming to the common messaging.
So you mentioned cybersecurity and talked about that a little bit. Speaking of that, HIMSS released your 2025 priorities. AI, cybersecurity was one of them, digital health transformation and workforce development. I'm curious, you set AI policy creations at the forefront of your list, I think on another podcast, but what are you working on from a AI policy creation standpoint?
So we created public policy principles literally, I think it's 11 months ago. We rolled them out the week after Labor Day last year. And because AI policy the AI landscape is changing so much, we're actually having a work group before the end of August of this year, in 2025, to be able to update. There's some key categories that we had missed. Liability is who's liable if something goes wrong. That's I think the hardest nut to crack. Risk-based regulatory framework is something that HIMSS has been supportive of in other environments for over a decade, but somehow it didn't make it into the final cut of our principles from an AI perspective. So updating those policy principles to make sure that they're relevant and consistent. Principles, you don't want them to change. You want them to be your foundation, but if you're missing key categories of how states versus the federal government should be able to approach something on AI policy, those are the types of things that we need to stay current on. HIMSS has been very vocal, particularly in the last few months, around the idea of making sure that we maintain innovation from an AI perspective, but we also respect the need for human interaction, or we've been saying learned intermediary for many years around FDA and medical devices, et cetera. But making sure that now that we've got this overlay of artificial intelligence, that's that we make sure that our policy approach is consistent and allows for continued information sharing, allows for continued improvement in patient outcomes. That's really what we're driving for from an AI perspective.
I want to shift a little bit and talk about this concept of a national patient identifier. So some people may not know this, but there's actually a ban on the federal government allocating dollars for HHS to create a national patient identifier. It's a law that dates all the way back to 1998. This is, before the HITECH Act, of course. So creating a national patient identifier conversations, they've really skyrocketed with passage of HITECH, with the COVID-19 pandemic. And there's a piece of legislation that is out there currently and recently proposed called the Match IT Act. So first, can you tell us a little bit more about what this act is, what it's proposing, and what we might expect to see in the future with this act?
Absolutely. So 1996 was nearly 30 years ago, and in HIPAA, one of the requirements was the creation of a unique device identifier, check, a provider identifier. Medicare rolled that out a bunch of years ago at this point, check. And then they were required to investigate and begin the process of creating a unique patient identifier. And as soon as the NCVHS, the National Committee on Vital and Health Statistics, which has been around since the beginning of the Kennedy administration back in the early 60s, as soon as they started, they had one hearing on it. The privacy community got really up in arms, put in this provision, Section 510 of the Labor HHS Appropriations Act, which precludes HHS from promulgating a unique patient identifier without first consulting Congress. 4 administrations in a row, Clinton, Bush, Obama, and really the second Obama is when they started changing their philosophy a little bit, but they refused to have any conversation around patient identification because they were of a misunderstanding or misreading or narrow interpretation of the provision. So but over the last decade, we've had some progress around, let's at least have a dialogue. Okay, you can have a dialogue, but HHS really can't participate in that dialogue. How do you have a situation where 60% of the care that's funded here in the United States doesn't have the major contributor involved in the dialogue around patient identification? So what the Match It Act is really intended to do is take not only while we remove Section 510, it's also the opportunity for us to have a process for testing patient identification strategies. So there's ways that people are identified, and it's algorithms that and it's perhaps it's biosensors and things like that. So being able to, the legislation gives HHS the opportunity to investigate and perhaps move down the certification process of what products, what approaches are best for identifying patients, and what products do it best. So that while we're removing the prohibition on having a national strategy or a dialogue around patient identification, we also are able to provide the type of information that's needed to show, hey, these are the best approaches. These approaches are effective, but with more resources, they could be even more effective. And then the provider community and the patient community have a better understanding or a better, more confidence in the fact that the identification strategy that's being used by St. Elsewhere is actually effective, and that the Tom Leary, there's 2 Tom Learys that live in Falls Church, Virginia. I'm 5'9", 185 pounds. The other guy is 6'7", 270 pounds. We both go to the same Ford dealership. We both, all these different things, But if I were to get his medication, or if he were to get my medication, there would be issues with. So being able to test and make sure that the strategy that the health systems here in my community are using for proper patient identification and what are the best approaches, that's really what the legislation gets to. At the same time, we're removing Section 510. Now, Section 510 was put in, as you pointed out, in 1998. If you're doing the math, Section 510 is it was the 1999 Appropriations Act, because at the end of 98 they get 99, the end of 99 you get 2000, et cetera. It's the way, because the fiscal year starts in October, right? So if that provision were a person, not only are they eligible to vote by alcohol, but they're now at the point where they have to have their own health insurance, because the provision is old enough that it would be removed from its parents' health insurance. So if you think about it, we went from an idea that we could have removed before it got to kindergarten, but instead it's well on its way to it's really negatively impacted patient safety and to information sharing and technology advancement in ways that we have to eliminate that provision. There are some in Congress that are holding fast to the idea that it's a slippery slope towards government having your data in ways and using it in ways that nefarious ways, if you will. We've got to get beyond that, because we're coming up on the 20th anniversary of the iPhone, and yet we still have this provision that doesn't allow for proper identification, of streamlined approach to identifying patients.
So just so I'm understanding you correctly, the Matchett bill that's proposed would repeal that law, the ban from 1990? No, it would not.
No, it's a parallel. We still have the appropriation still needs to do that, but in lieu of that, and as part of the process for educating members of Congress, is how do you get the certification? How do we create a process that demonstrates that which are the best ways to certify or to identify a patient? That's what the Matchett Act.
Okay.
I'm sure there's other provisions that I'm forgetting about at this moment, but that's a key component to it.
So the Matchett would not allow us to create a national patient ID. It would just put more stipulations in place, and checks and balances in place for organizations to make sure they're treating the correct patient.
Yeah, it would really address some of what the privacy community is concerned about.
So is that good enough, or do we still need a national patient identifier, in your opinion?
Well, it depends on who you talk to within HIMSS, but I think we need a national strategy around patient identification. Whether or not we need a single patient identifier, there are other ways to identify patients that's very effective. So having a national strategy around patient identification is really what HIMSS is most supportive. And the Patient ID Now Coalition, that's what we're really pushing for, is eliminating the barrier to creating that national strategy. Other countries, you talk about the Netherlands, for example. They have it to the point where the patient, they know each building has an identifier, each floor has an identifier. So if there's a fire in the Chipotle down, 5 stories down from where I'm sitting, and they're able to determine what the smoke patterns were, which apartments, which offices, which individuals were impacted by smoke inhalation, or might need extra attention, and that because they have a strategy for patient identification. In the United States, we don't have that benefit, and therefore population health is perhaps less effective, because we can't say these 5 people were exposed to the smoke inhalation, but that's a bit, that might be a little bit of a stretch. So patient identification of knowing who was exposed to, COVID, the app and how that worked, how those different apps worked during the pandemic, taking that to other healthcare situations, being able to then have population health exercises to be able to, mitigate, outbreaks, things like that. That's really where it can be very helpful.
You mentioned this a little bit, you touched on it, but Rand Paul, ACLU, and a lot of others have been big opponents of creating a national patient identifier. So they say it creates privacy concerns, too much risk for security breaches, gives the government too much access to patient data. What do you say to this? Do the benefits outweigh the risks?
Yeah, I mean, there's, the cynic will say, well, you've given away all of your, there's so much data being driven by all the different apps you have on your phone. Your shop.com and knows more about you than perhaps your healthcare provider because, whatever. So there's, the train has left the station, perhaps, on data sharing in other sectors. But getting beyond the sarcastic is really having a patient identification strategy helps us know who needs what care, that the right person is getting the right care at the right time. And really, it's bottom line, it's a patient safety issue. From a privacy and security perspective, paper records gets compromised all the time. They either get lost, they get stolen. So it's one could argue that digital healthcare is more secure than paper-based healthcare. One, and then secondly, with respect to cybersecurity, we were just talking earlier today about the idea of a lot of since healthcare is the top three categories for sectors for having cyber attacks and ransomware and all those different kinds of issues. You see more and more sophisticated companies coming into healthcare to help with cyber protection. So as the bad actors get more sophisticated, the defenses need to get sophisticated, and there's more. You see from the HIMSS security survey, most recently from 2024, that we're now spending somewhere in the neighborhood of between 12 and 16% of IT spend is on security, which is a very big step in the right direction. So all the concerns about privacy, we have potential solutions for that, and if we all work together, it really does overcome that concern. And we're 19 years past the iPhone. So we've got to make sure that the way that we identify patients stays current with current innovation.
And not to mention, a lot of other countries around the globe have already implemented, national patient identifiers. We're one of the laggers with that. If you talk to a guy named Nick Ulicki, he used to work for the Ways and Means Committee. He said that our intention was the upgrade of the CMS, the Medicare number, getting it away from the Social Security plus to this new Medicare number that's really intended to help teach the country that you can have a patient identifier, whether it's a single number or a very sophisticated algorithm that identifies the right person for the right care at the right time and is secure and private. So, yeah. So HIMSS published a report a couple years back recommending an investment of over $36 billion over 10 years for public health infrastructure improvements, modernizations, in order to better respond to issues like, health equity, pandemics, emergencies, disease reporting, so on and so forth. The report was issued, I think, about 3 years ago. So where do we stand today? Is it being funded appropriately? Where are things?
Thank you. It's if you think about how we've gotten here, and what we've gone through with respect to the pandemic, the report that we published there was a question during the pandemic how much this coalition, this data partnership, this data campaign, you've requested $100 million a year for 10 years, and is that really the right number? And quite frankly, HIMSS has been saying since the beginning, $100 million a year for 56 jurisdictions to upgrade their data systems is it's not even a single drop in the ocean of the resource requirements. So the question came from the Appropriations Committee: what is the real number? And so the public health community got together and we helped support it, and they put together a number that was one level of sophistication. Our team took it still a couple steps farther and came up with that $36 billion over 10 years. So the first part is a $26 billion investment, a minimum of a $26 billion investment over the first 5 years. And then in order to get to a learning health system, that's where the other $10 billion investment would be. And, I think there's two things to identify here is that during the pandemic, we got $1 billion in investment. And public health departments were able to upgrade in some ways, and they were able to hire some new staff. And then, as recently as late winter, early spring, the Trump administration and CDC clawed back, somewhere in the neighborhood of $115 million from communities and from public health departments. So it was no year money that was intended to hire staff or make upgrades that was going to take longer than your average, year or 1 year appropriations or like a clump of, sometimes Congress does, or you have 4 years to spend this or 5 years to spend this. This was no year money because they realized that if you just give them a little bit of money or a little bit of time to spend the money, they're going to spend it frivolously. Or just quick, we got to spend it before they take it back. And so the communities were saying, this is no year money, but we know somebody's going to come along and take part of it. So they're very diligent about how they spent it. And quite frankly, that, the new administration did come in and take a portion of it back. So are we where we could be? No. Should those funds be allocated back out to the communities? Yes. Are we anywhere near $1 billion a year in investment? No. So if we're truly talking about traditional clinical care having an equal partner, having a partner that they can rely on in public health, then the investment is absolutely necessary. Is $36 billion the right number? We're actually in the process of trying to determine, if the more you don't invest in IT, the more of a technology deficit that you have. So over the past 3 years, how much have we caught up, or how much of a deficit do we still have? So we're in the process of determining, do we update the report? How do we update the report? Do we bring more economists into the situation, et cetera? But quite frankly, public health is still not an equal partner. Data modernization in the public health space is absolutely critical to preparing for whatever comes across the transom. I like to use 2019 as an example of when we announced the data partnership. In January of that year, we had the measles problem. By August of that year, there was the lung disease that was high schoolers and early, teens and early 20s were experiencing from the vaping, the trend in vaping. By the following March, so within a 14-month span, we had 3 major issues, because the third one being the pandemic, right? So just this year in 2024, August of 2024 to now, we've had measles outbreaks, we had other public health issues. So the idea of investing in the public health data modernization is whatever comes across the transom, whether it's a problem with the water system, whether it's a disease that comes from a portion of the world that we haven't had a response for or prepared for. That's having the data systems to be able to alert and to properly respond. We're not there yet. The other piece of what we've been advocating for is the Center for Forecasting and Outbreak Analytics. It was an investment that was made during the Biden administration, that is getting less funding both from Congress and from the Trump administration. In 2024 alone, they identified 5 problems from outside the U.S. and stopped them at that border, rather than having them come into our borders and then our health system being taxed, by having to address something that wouldn't. That it would have just become not a pandemic, but just an outbreak, stopping an outbreak from happening in a community. You remember from a few years ago when Ebola made its way into Texas and in Louisiana, the Center for Forecasting and Outbreak Analytics has been established to identify those kinds of things as they're happening in other parts of the world, help those communities react, and also help those people that have been exposed from traveling to the United States. By underfunding that effort, we're putting individuals at risk. So that's the other part of the data modernization story. You have to have the data, but then you have to be able to analyze, to be able to prepare for and mitigate what's happening offshore so it doesn't come to the United States. There's a WHO Europe podcast from last summer, where as a virologist was being interviewed by another member of the WHO, and they said, "What's your biggest concern?" He said, and the response of the virologist, and I'm paraphrasing, is basically, our biggest export out of Europe, out of the European region, of those 53 countries, is disease. And because people are concerned about the misinformation about vaccination, and yet they still get on airplanes and go to other parts of the world, and they expose those parts of the world to the diseases that we have and that we haven't been able to control. You're seeing that. You see that in the measles outbreak. You see that in other things that come to the United States. So if we don't have the data modernization situation right here in the U.S. We don't properly fund the forecasting and analytics, and we have an overall issue with vaccination rates dropping 10, 20% across the globe. We're inviting a situation that technology could help mitigate, but we have to properly fund.
So how is HIMSS going about trying to get that proper funding in place?
Sure. We work twofold, really, working with the administration and making the arguments for proper requests out of the president's budget. So, the administration's attempting to rearrange how HHS does business and what agencies exist, and agency consolidation. So there's education and conversation with the administration. At the same time, working with Congress on proper funding. So answering the questions of what's the right level of funding for data modernization, and then showing, whether it's through our maturity models or other capabilities, showing that the investment has been worth it. So the CCOM looks at, and the digital health indicator, they both tie into showing that there has been proper investment has been made, and this is the preparedness as a result of that investment. And we're working very closely with with our data partners. The Council for State and Territorial Epidemiologists, the Association of State and Territorial Health Officials, and big cities, and National Association of City and County Health Officials, and the data folks at states were part of the core group that's been in place since 2019, and we've now expanded that group for market suppliers and health systems and others that are interested in demonstrating to the government the need for the investment. So there's been a doubling down of the data modernization community, if you will.
Well, Tom, I couldn't let you get through this podcast without asking you about the One Big Beautiful Bill. So any thoughts there on that act and impact?
We're very concerned about a couple of items in the One Big Beautiful Act at this point. It's the potential decrease in funding from Medicaid. We've heard as high as close to $1 trillion in decreased funding. That has our members and just quite frankly the healthcare community very concerned that you're either going to have individuals that don't seek care, or you have, because they don't have the coverage anymore, or you're going to have states having to make very pre-Obamacare decisions of who's eligible to be on the rolls, who's eligible to receive care, and in health systems that are already, many of which are, barely in the black or just right, their margins for keeping their doors open are being strained already. You have that additional strain. It's going to have an impact not only on care delivery, but it will have an impact on technology purchasing and therefore the efficiencies that can be brought to bear. Those are the types of things that we're concerned about. The other component that we're paying close attention to is the tariffs. We've had members point out to us that we've had 20 plus years of the healthcare community, the ecosystem, having a company might be U.S. based, but component parts might be made elsewhere, and the supply chain for medical devices and other equipment has been shared across the world, so that if you have to make a decision around, we had one board member point out that they're going to turn more of their attention to emergency care because of the changes in Medicaid are going to perhaps have more people coming in through the emergency department than they're through the regular parts of the system that have been established over the last decade. Instead of making investments in radiology, advanced radiology equipment that can detect tumors at earlier, those kinds of things. So that's really what we're primarily concerned about right now. We're still learning about the impact of the legislation, and our analysis isn't complete yet.
We did a podcast last month with Ryan Cross. He's the VP of Government Affairs at FMOL Health System out of Baton Rouge. And he mentioned we may expect to see some bills proposed that actually peel back some of those Medicaid cuts that were just passed. Any thoughts on that? Do you know anything about that? What are the odds of any of these Medicaid cuts getting pared back?
The challenge is really going to be what you pay for then, and and do those pieces of legislation get enough traction that I think he's right about the being proposed. It's which ones can we all get behind that have the most probability of passing. I think that's going to be a challenge. As we still don't have appropriations for next year, which on its face is a problem, but quite frankly, we've been living off of omnibuses and continuing resolutions for decades now. So regular order is I don't know that it's even being taught in the history books because it's been so long since we've really seen year over year that. But between now and the end of December, getting the appropriations, getting the country a proper funding for appropriations, and in the fiscal potential for another fiscal cliff, with the debt ceiling issues. Those are all going to be front and center. It's these other issues that around fixing what was in the One Big Beautiful Act. That's going to be a challenge to get on the legislative calendar, particularly when they get back the day after Labor Day. Congress only has 18 days of planned legislative action between now and when they go back to their districts and states for the remainder of the year.
Well, for those that are unaware, Louisiana, Mississippi, and Alabama HIMSS chapters put on an annual conference. Every year it's called GC3. We've been doing this for 10 plus years. So this year GC3 conference will be held in New Orleans. It's September 24th to 26th. For anybody interested in attending or sponsoring the conference, you can go to gc3conference.com. Tom, you're actually going to be one of the speakers there at the conference. Anything you can tell us about what you're going to be speaking about?
Yeah, diving deeper into some of these topics that we've talked about today, and really understanding, with over the next month, we expect to have even better understanding of what's happening with the One Big Beautiful Act, and what's the practical implications that we're starting to see. Some conversations around the last couple of weeks before the November elections in New Jersey and Virginia usually are bellwethers for what might happen in the midterms the following year. And so those kinds of issues, plus, quite frankly, really getting some feedback on some changes to our cyber principles and AI principles that we'll be rolling out as drafts between now and the conference. So I'm really looking forward to it. I haven't been to New Orleans in a few years, but I appreciate the invitation from the three chapters to be part of this. You have a very influential conference in a very influential part of the country. I'm hopeful that Senator Cassidy will be able to join us because he's so important to all of the topics that we've been discussing today.
Well, Tom, thank you so much. Looking forward to seeing you at GC3 and appreciate your time today.
Awesome. Hey, we'll see you in a couple of weeks.
Okay, sounds great.
Thank you.
You have been listening to the Louisiana HIMSS Podcast, where we have engaging conversations with Louisiana healthcare leaders. This podcast is a production of the Louisiana chapter of HIMSS, the Healthcare Information Management Systems Society. If you would like to learn more about us, please visit us at louisiana.himss.org. That website again is louisiana.himss.org. You can also find us on LinkedIn by searching Louisiana HIMSS, or just email us directly at louisianahims@gmail.com. If you found this podcast engaging, please like and share it. And don't forget to subscribe so you don't miss our upcoming podcasts. Thank you so much for joining us, and we'll see you next time.